Okay, Mr. Chair, we are live and I can start the recording whenever you're ready.
Great, thanks, Rob. Good morning, everyone. It's the, okay now, Rob?
Yes, you're good to go.
Great, thanks. Good morning, everyone. It's the Mental Health and Addictions Task Force meeting. It's June 21st, 2022, 9:30 a.m. I will call the meeting to order. I think it's appropriate that on this day, I will acknowledge that today is National Indigenous Peoples Day. And I was at the Reconciliation Garden at the crack of 5:30 this morning for the sunrise ceremony, and along with Francesca. With that, we'll move to number 2. Is there a declaration of interest? Seeing none, if one should arise, you can speak up at that time. Number 3, supportive outreach services, SOS, Grey County Paramedic Services. I'll introduce Director of Paramedic Services, Kevin McNabb. Kevin, you have the floor. Good morning.
Good morning, everyone. Can you see my screen?
Yes, sir.
Okay, thanks. Well, thank you for having us here today. This presentation is actually a group of community partners and myself presenting to you on supportive outreach services. So with us today from United Way is Francesca Dobbin and Sandra Hoyler. From CMHA, we have Scott McKay and Stephanie Burley. From Graybridge Health Services, we have Heather Prescott, who's a nurse practitioner. Robin Nasilla is a nurse practitioner. Dr. Libby Cox is a addictions physician, as well as a family physician here in Owen Sound. Our CPs, Darren Clark and Sherry Foster, as well Samantha Caldwell from Ontario Health West. And just to start off, if it's okay, Dr. Cox and Robin Nasilla are going to do a brief presentation on the goals and of addictions treatment and therapy and opioid agonist treatments. So I'll hand the floor off to them, and then we'll go into the SOS presentation.
I'm just sorry, this is Dr. Cox. Hi, I'm just checking to see if Robin's here yet.
I am, yes. Hello.
Oh, wonderful. Hi, Robin.
Hi.
Perfect. I'll let you get started. I am coming over from COVID, so my voice has gone, but I'll contribute when needed.
Great. Thank you. Kevin, was there a slide, or we're just going to talk about the medications?
Just talk to the medications if you don't mind, or I can put up the slide too if you want to.
Sure.
Go. Okay.
So my name is Robin Nasilla. I'm the nurse practitioner with Graybridge Health Services in the addiction treatment program. I have been involved with SOS and RAM. And so my role predominantly is within the diagnosis and treatment of addiction. And the majority of medications that we use, we try and stick with what we call first line treatment. So this is evidence-based treatment on how to help an individual either stay sober, so off of a certain drug, whether that be alcohol or opiates, stimulants, marijuana, or harm reduction, which is helping that individual use less. So when we're talking about treatment, first line treatment is, you often hear of Suboxone. So Suboxone is 2 drugs, buprenorphine, naloxone. And what you have to understand is Suboxone blocks the receptor in the brain that's activated by opiates. That receptor is what makes that individual feel cravings, have withdrawals, and get high. So this specific drug will block that. And ideally, if that individual uses, they won't get high. So it helps with both reducing use and maintaining abstinence. As well, this medication is not sedating as other medication are. So there's a really nice safety profile for medication. So that patient can have doses that they can take home sooner than later because of the safety profile. The caveat to that is they have to take it. So they have to be willing to put it under their tongue and let it fully dissolve. If they were to chew it or swallow it, it doesn't work. The other thing is once they have doses at home, they have to be reliable to take their own doses. So sometimes you get where patients only want to take it to relieve their withdrawal symptoms. and they don't necessarily follow the regime that we prescribe. So that's Suboxone. It really is a great drug. It's fully covered. And it's the drug that we're using with SOS to start people on right in person, at home, at withdrawal management, in hospital. The second substance or drug that we provide for opiate agonist treatment is methadone. So methadone's been around for a long time. Methadone is a much more difficult medication to monitor because there's more safety risks with it. It does cause sedation. However, it is still a good option, especially if patients aren't ready to fully commit to being abstinent. Methadone will occupy the receptor as like the substance opiate that they're using, and it will reduce cravings and withdrawals. Predominantly, though, they can still get high while using methadone until they get to a certain point, and that's where the physician gradually increases the dose. So when we're looking at the difference between Suboxone and methadone, one, we can rapidly increase and stabilize the patient very quickly within a day to 2 days. Methadone takes a lot longer and a very gradual, slow increase because it is sedating. It's also one that they have to be on for a predominant period of time before they take doses home. Where Suboxone, we can give that dose to take home much sooner, much quicker because of the safety profile. Alongside methadone, when you have patients that are still using on top of it, they want to reduce their use, but they're not fully committed at this point to fully quit, whether that be trauma, whether that be their source of living, whether that just be their choice. You will also see the physicians and nurse practitioners prescribe a long-acting morphine called Kadian. So the Kadian is basically allowing the choice to use less fentanyl or less opiates because the Kadian will occupy that receptor. And then the methadone is that long-acting relief of cravings and withdrawals. And Dr. Cox can jump in on that part at all because we are in that piece. We see a lot more Kadian methadone in our reserves at this time, both with NAWASH and Saugeen. And it is a patient's choice. So when we providers offer treatment, we're going to offer all choices because it's unethical to not offer a choice of methadone or Suboxone, possibly be topped up with Kadian. And then our third choice is something called Sublocade. So there has been a lot of conversation around Sublocade. Sublocade is a once-a-month injectable. It's a long-acting dose of Suboxone. So instead of taking a pill every day, they get an injection in their abdomen. It's once a month. And it actually is equivalent, one injection is equivalent to that of 16 milligrams or higher, and blocks that receptor actually within that first injection. The piece around that is they actually have to be stable on Suboxone for a period of time, ideally 7 days, but we are doing something that Timmins doctors have been doing, which is something called a macro induction. We give them high doses of Suboxone fairly quickly, especially if they're IV users where they have a higher risk of overdose. So we get them into withdrawal, we give them a high dose of Suboxone, and then within up to 36 hours, we can give them their first injection. There's new evidence supporting that buprenorphine is actually overdose protective. So if somebody is on, say, a long-acting Sublocade, it actually, the evidence is showing that it's preventing overdoses. And I did have a client using up to 10 points of fentanyl a day IV on Sublocade, did not overdose. It only is protective against opiates. So the piece that we're seeing is that, unfortunately, drugs are no longer clean anymore. And the idea of clean is it's just one drug. A lot of our drugs on the street right now, as I'm sure everybody's aware, have mixtures of things in them. The most dangerous one right now is the benzodiazepines within the opiates. So etazolam is often what we hear in fentanyl. And it creates a sedative effect. So it gets them as close to being very sedated, which inevitably creates this insane high for them. The problem with that is it can fully sedate them to the point where they have respiratory depression and death. So the overdose is not necessarily from the opiate, but can be from the benzodiazepine, which in using opiate agonist treatment like methadone or Suboxone or Sublocade, benzos are contraindicated. They increase that risk of oversedation or death. So it's not making our job any easier when we're having drugs that are combined with other drugs that have stuff in it that's contraindicated. So I'd love to tell you all that, you know, everybody's ready for treatment, but they're not. And I think the most difficult piece for anybody on the sideline looking at addiction is that we don't fully understand recovery. So recovery really is what that patient wants. And that recovery may be that they want to use less. That recovery may be that instead of IV, they want to learn how to snort or smoke their drugs. That's our role. It's no different than if you went to the doctors and you had the choice of, you know, birth control for women or high blood pressure medication. We're going to give you the education on how to use that medication properly and what your choice is. But you also have the choice to not use that medication at all. And so when our patients, such as those from the rooming house, were forced into an option on do you want to use or not, their choice is that they would like to use. That's their choice. And unfortunately, we don't have anywhere that's going to accommodate that choice. We saw that a lot, and I'm sure Kevin's going to talk about it with the hotels and certain rooming houses and things like that that don't even allow for safe use. So I think that's the difficult part when we're treating people is if you force somebody into treatment, they're not going to be successful because it wasn't their choice. They don't want it. And we have, hopefully Heather's going to talk about some really nice cases of patients that we've really worked with in their recovery goals for over a year before they chose abstinence as their goal. And, you know, I'm just as proud of those people who choose harm reduction and use in a safer manner or have used less as I am for those who are abstinent and have chosen to maintain sobriety, because addiction is not linear. It's very cyclic. It doesn't go A, B, C. Robin, you know, is using, she wants treatment, she gets treatment, she's cured. Addiction is a chronic disease, and these individuals will have it for the rest of their life. And it's really about building their skills and their confidence in our healthcare system, in our providers, in our community, to understand that they're not stigmatized, that we do support them, and that we're supporting their choice, whether that's abstinence or use. So if you have any questions regarding treatment, please let me know.
Robin, I just wanted to ask, I might be a little bit surprised at what you just said about recovery. I understand recovery is different for everyone, but what someone can actually use during their recovery, and that is still looked at as recovery?
Yes. So when you think, Brian, when you think about addiction, how it was presented a long time ago, we looked at addiction from an AA perspective, and AA was very religious-based, no use, complete abstinence. It doesn't work. The majority of people who want abstinence, 100% it works for them. But there is a large population of people that just aren't ready to, whether they're ready to give up that lifestyle, whether they can give up that lifestyle, again, with housing and support, whether they're, you know, able to focus on trauma. So a lot of our patients have a lot of trauma, and they're not ready to deal with that yet. And sobriety brings on emotions and memories and things that people just can't tolerate. And so when we talk about recovery, if we can tell, or we can talk to somebody and they can use less. So say their goal is, you have somebody using crystal methamphetamine, and their goal is that they only want to use on Saturdays because from Monday to Friday they work. Then to me, they're still in recovery because they're maintaining that option and that choice until they feel that they're stable enough and choose to be abstinent. Does that make sense?
Well, it's a learning process for me, and I think that's what happens for people like me on the outside that don't understand it. we've always, or someone like myself have always looked at someone as, if they start again, then they've blown it. They're back to square one, or they're using again, or they're drinking again. And I just find it interesting that this is, it's different now, and we all need to learn this.
Something
any
that we often like to say is that the opposite of addiction is not abstinence, it's functioning. So it's the ability to function in life, get back to those things that people find important to them, whether it's the land, whether family, work, those kind of things, because those are the first things to go. So that treatment is related to helping people function.
Right. Thank you. Okay, any other questions for Robin? I can't see anyone, so Kevin, I'll just go back to you if you want.
All right, I'll go on mute and let everybody else talk.
If anyone can use if they do wish to speak, use the raise hand function, and then I can keep an eye on the chat or the list to see who has questions.
Okay, thanks, Robin, and thanks, Dr. Cox, for that. And I think it was important for people to hear that about what those goals are and really what the team looks at out on the road each day when they're facing our clients and trying to get them to move in this direction and again, meet them where they're at. So a bit about SOS and how it started. It was just over a year ago now in Southern Grey County in a rooming house. There was a Delta outbreak of COVID-19, and working with public health and multiple community partners, we all formed around this group of individuals, around 40 people, and supported them. Most people at that time were suffering from mental health and addictions, and our goal was to keep people safe for that time period when they were in isolation and couldn't more or less leave the property. We came at this with a harm reduction lens, and the goal was to keep people safe for that month. And between the medical care, treating COVID, treating their addictions, treating their mental health, and very importantly, offering the social support, we were able to do that and keep them safe. And through that month, we actually seen significant health improvements in people. And as we were winding down that month, as difficult as it was for them and us, we actually, could see the improvements, and from the residents themselves, they were asking us not to leave and stay engaged. So we looked at an exit plan and how we would exit out of there, and we gradually decreased our services to, a couple times a week, and then once a week, and then we actually now stay connected every other week in that area. So in that time, that we worked through the summer and into October, the community partners, we continue to work as part of SOS. And with the issues we were having in Hanover, and then also what we were seeing in Owen Sound, we actually started to develop the same type of program and those same type of services, offering them in the city of Owen Sound and Hanover. One thing that I learned through the COVID outbreak at the rooming house is in healthcare, we always think of ourselves probably as number one, but I think I was wrong in that. I know. When we're focusing on helping our clients, their number one goal is really the social housing support. They're thinking about a roof over their head, food. Obviously they'll have the concerns with their addictions and mental health and dealing with that, but the health importance really doesn't come into effect until you address those needs. And for us to address those needs, it's very important that we not only look at healthcare partners, but our community agencies to support, again, housing, social services, food, clothing, all our other agencies to support this. And I can't say enough about the partners that were involved with this and made this possible. As far as organizing the project from the beginning, public health was the lead on the case contact management in the rooming house. And then with the work that we were doing, as far as developing this framework for this project, they've maintained that lead role, and they continue to work in this role with the planning and development. We have a whole committee that works on this, They're looking at the model and making sure that we're meeting our objectives, looking at the framework for evaluation. They've already done an evaluation for Ontario Health West, and they'll actually be working on a more robust evaluation for late 2022 or early 2023. And also with that, they do have experts in health equity impact assessment, and they are looking at areas of equity challenges and ways for us to mitigate those equity challenges. So we had continued on with these markets, and we call them the market. It's really an outreach market, again, with all our community partners. And one thing that we were finding was that in between the market days, between Hanover and Owen Sound, we didn't have the connections during those off days. And what was evolved at that point was the need to develop a mobile SOS, supportive outreach services. And just by chance and really good luck, I guess, Ontario Health West was actually approached us just around Christmas time and asked us if we would be interested in doing this type of work. And I'm so thankful for Samantha Caldwell and Ontario Health West. She's here with us this morning, and they've contributed to this project. It's close to $500,000 now to get us through till the end of March 31st, 2023. And also thankful to the local Grey Bruce Ontario Health team and Lauren Gardner, where we worked through Christmas to develop this project as far as a mobile team that will go out in the community. So this is the structure of our SOS outreach services for the mobile group. You can see here that we have addiction specialist physicians, that's Dr. Cox and Dr. Travers, community paramedics from Grey County Paramedic Service, and nurse practitioners with addictions background, primary care from Grey Bruce Health Services, mental health counselors from CMHA. And one thing that I'm real proud of, and I know it's so necessary and interesting that health supplies this now, is health dollars to fund the social navigation. And we have a social navigator from United Way. So we work together Monday to Thursday with this team, going out, working together. And you can see here, we're still supported by our multiple community partners that help us in the background and in the foreground or wherever we need them to support our work out in the community. And we deliver medical care. There's addictions treatment happening right on the street, mental health crisis and comprehensive mental health care, COVID-19 assessment and treatment with vaccinations. We even had people start on therapeutics when different outbreak situations. And very important is the wraparound social care and the navigation of the system for people that may not, and almost all of them are not at the point in their journey to navigate this complex system. So just a bit of brief about what SOS has been doing since the 1st of February, and recognizing this is a new program, and it comes with its challenges and we have to evolve, but everybody is working really hard. You can see the number of client interactions, over 1,200, and 439 unique clients or patients or persons that we treat. 1,650 harm reduction supplies, and that could be anything from a safe use kit to naloxone distribution. Basic needs for their social support, and also the medical interventions, close to 400 of each of those. Supportive services that we offer right on the street, counseling, primary medical care, addictions treatment, health teaching among some of the higher ones, but lots of services for support provided. Basic needs on the social support side of things, of food and clothing and personal items. Medical interventions, again, performing medical interventions right out on the street, whether it be giving people addictions treatment, COVID-19 assessment, treatment, vaccination, wound care, drug screening, treatment for even wounds or even infections, those type of things, drug screening and screening for sexually transmitted diseases all takes place right on the street. Referrals, again, back to those community organizations, we can't do it without them. So our larger ones are around housing, social services, and mental health and addiction services. Just a bit about our fixed sites, just to give you some stats for them. Again, mostly this is in the Hanover and Owen Sound area, but we have done some pop-up in Meaford and a couple other hotspot locations in Grey County. But we see significant number of people at these locations as well. Since February, we've seen 1,347. And each day we bring a meal for those sites, and that's what brings people to our services. Again, it's not about the healthcare, it's the social support that we can provide people. And, Colleen at O'Share and the work that she does, 1,320 meals, and Salvation Army with the food hampers, partners with public health and CMHA around harm reduction supplies. And then again, all the other agencies that come and provide services at these outreach markets. And just to give you an idea of some stats, 60 for peer support, there's multiple counseling, housing applications. In Hanover, we actually run court services right at the facility. There's employment support, housing consultations, Ontario Works interactions. The markets are really a place where we can get together and have all our agencies in one spot, where when they show up, there's not much that we can't handle or deal with when our clients show up for support. Okay, that was just a bit about SOS, and I did kind of go through it a bit quickly, but I wanted to get to these next slides to talk about the work that SOS is actually doing. And I will have a number of partners. We'll go through these slides, and the first one is Francesca is going to talk about the importance of social support.
So Sandra, who is on the call, and if she wants to jump in, absolutely, she can jump in too. Stuff is the currency of trust for us. So, we can give out 1,000 pairs of socks through mobile sites as well as stationary sites. But what it does, it starts a conversation and it bridges. So people may have trouble connecting to services. They don't know the hours. There may have been a breakdown in a relationship. Well, I used to go there years ago. I know I'm confused as to how things are running in a during pandemic as to, this service used to run like this before the pandemic. Gosh knows what's going on with it now. So Sandra, who's our social navigator with me as an inferior backup to it, can work with people, work with agencies, make calls and bridge the round holes in the square pegs to connect people to the system, to other services, deal with any red tape, or simply just go, yeah, you know what, that's crazy, but I'm going to go up the ladder, the chain of command, and see what we can do to meet your needs. And it can be as simple as understanding that, sometimes you need a granola bar for somebody who has no teeth. And so our food needs to accommodate that. So, hey, Colleen over there, Share, Alice, I need some granola bars, breakfast bars for people with no teeth. So those are those things that make that connection. We had one of the fire victims was staying in a trailer on an old futon, just needed a better mattress. Jump in the car, run to Walmart, get a mattress that they can throw on top of that futon, and a really good pillow, because in the conversation, dislocated his shoulder a couple of weeks ago. So neck and shoulder issues, we're going to get you a really good pillow instead of just a cheap ass pillow. And that way, you can sleep better. If you can sleep better, you can work better, was working. And that's a continuum to a life they want to live. So happy to answer any questions around that. And as I said, Sandra's also on the call and can answer any questions too.
Sorry, Mr. Chair, if I may bump in, I think Kim had a question or a comment as well.
Okay, Kim, go ahead.
Sorry, Kevin, I just wondered back a few slides there where you talked about the access to primary care from the mobile site. And I just wondered if you could just touch on that a little bit. If that primary care access wasn't being provided, would these people go to the ER or to their family doctor? That that's not the answer, but I think it would be important for the committee to understand where these people are at health-wise.
Yeah, and Heather's on as well, and maybe I'll take the first part and she can take the next part. But typically what we see is that, again, back to the health needs, these people are sick And they may not even recognize their health conditions or concerns until we lay eyes on them. And then first off, identifying that they have a health problem and that they need to get looked at. And we've seen that where we've seen significant health issues in people, and we literally have to go find them because we're worried if they don't get their antibiotic that they will not do well based upon what they're presenting with. And then there's the other side of it is the trust and the stigma. Some of these people have been wronged by the healthcare system and they may not want to access their healthcare at this time, and just navigating to that system. Like we'll talk about the navigation down the road here, but I believe that we need to walk alongside our clients. You know, they as far as accessing the system, they don't even know where to start to access it, let alone the only place that they have to access is Emerge. You know, some of them may or may not have primary care providers, but most of them don't. And it becomes very complex. And again, even just getting that trust. So I don't know, Heather, if you can add to that, I guess.
Yeah, I certainly can. That's great, Kevin. The studies do show that the homeless population typically lives a lifespan 30 years shorter than their counterparts, and less than 10% have access to a primary care provider. So there's innumerable barriers to why that might be. A lot of folks have had negative interactions with the healthcare system previously, and choose for a number of reasons, either not being able to or choosing not to access traditional services. A street medicine approach is an emerging model of care that helps reach these most vulnerable folks. And in some ways, it has a significant advantage in the time that I've been providing this kind of street medicine. The trust that comes from being able to be flexible and reach people in their own home or their own setting certainly improves the ability to form trust and to really get a much bigger idea of the health determinants that folks are actually living with, and meeting them where they're at, and making goals and appropriate interventions that are going to serve them. I know the paradigms we use in traditional medicine often aren't appropriate and aren't going to work with those individuals. So going where they are, our outcomes and our trust and our follow-ups have been much, much stronger.
Kevin, just before you carry on here, I just wanted to back up to, you had mentioned public health at the beginning, and I just want to acknowledge that Dr. Zayed, because I know she made such a big difference in taking the lead in the beginning and planning the SOS program. And Kevin, I want to thank you for the way you've presented this, because you talk about collaboration. There's so many players in this program, and it works, and it's fantastic the way it's all come together. So thank you for that, and carry on.
Yeah, and I can tell you the truth, like when this all started, it started with public health. I remember the phone call that we had to get together. We had a problem down in Southern Grey County, and we had to come together to support and that leadership through the summer. And then we all branched into this, and we were an operations team, but in the background around case contact management and strategic direction, that all come from public health, and so thankful for that. Next is mental health. This will be Scott.
Kevin, just before you get going, we have a question there. Warden Hicks, go ahead.
Yes, thank you, Mr. Chairman. I have to go back a little bit to Robin's presentation, and we folks on the outside who are not sort of in this game and trying to understand it, and getting your head around the fact that someone who is still using could be considered to be in recovery. And bringing that now to my other life when I practice criminal law, and you represent someone and they've committed a crime and they may be an addict, and their bail conditions might say you're going to abstain from the use of anything that's non-prescription. But Robin tells us, and I think quite rightly, that that person may very well be in recovery, and no use may not be. It's really just setting that person up for a failure and as a repeat offender. So now I'm going to be charged with a violation of a breach of my bail conditions. I just wonder if Robin or anyone with experience might my comment about that, because it strikes me as another area that we really have to look at. There needs to be some education, I think, in the criminal justice system.
Robin, are you still on? Just checking here. I'm happy to take it though if you are gone now. So thank you for pointing that out. And we know now that using even urine drug screens as a punitive measure in medical care only serves to create a situation where individuals are going to fail, and only identifying recovery as complete abstinence in a chronic disease it doesn't work. There's not a lot of evidence behind it, and people continue to fail and fail, and then leave the healthcare system. So this approach, this harm reduction approach, can be anything from offering safe use. It can be anything from drug testing to see if there's fentanyl in their product. It can be drug treatment, and it can be abstinence-based care. So there's a wide spectrum of services that can be offered, like any disease, depending on where they're at in their disease process and where they're at in their recovery goals. So having an aligned plan, aligned goals with the client, far more effective. And I would imagine it would be very similar with the criminal justice system as well. I mean, some people go to jail because they're 3 square meals a day and that they're able to abstain in jail. But that's not their goal. It's forced.
Yeah, there is that. And then there's also, and I don't believe it's practiced anymore, but when I did do child protection law, quite often clients would be subject to, hair follicle testing, for example. And if you had drugs detected in your hair, then that could impact your visitation with your child and ultimately the relationship with your child.
Absolutely. That's very, very complex, but I think also goes to highlight the stigma attached to why individuals do not seek help, do not seek treatment for so long, because it has been so punitive with past experience.
If I could jump in, we do have our court support programs, both for mental health and addiction, where we can intervene if we get a referral from prosecution or sometimes through police. And there's an opportunity for individuals to access care and then be reevaluated by the court. So there are those mechanisms. In some jurisdictions, there are specialized courts as well for mental health and addictions, where people are the judge and counsels are a little more have a little more education on it. But it's definitely when you look at the subpopulations and the rate of concurrent disorders, being addiction and mental health, those that come in contact with the law, about 98% will have a concurrent disorder. So.
Heather, you just mentioned it's not recovery, it's forced. So if a judge said, and I brought this up before, if a judge gave a person the choice of 3 years in jail or 1 year of some kind of counseling, both are forced, but would the counseling not work then because it is forced?
That may be a good one for Clark. I mean, I don't know if I can say one way or the other, but having a patient engaged is far, far more effective.
Yeah, it is an issue, and Stephanie can comment on this as well. But certainly speaking with the workers in those programs, it can be a little more work to engage them. But Steph, do you have anything to say on that?
Yeah, just to echo that. I mean, client engagement is so critical. You can't force somebody's mind, right? People have to be willing participants in the process. Like Heather said, this is a chronic disease. This isn't just something that you can snap your fingers and decide, hey, I'm going to stop doing this. The definition of addiction is something that you continue doing despite those negative consequences, right? There's a compulsion to use. There is a need to use based on the person's lived experience, a lack of coping skills, trauma that they've experienced. A lot of times people are self-medicating right? So I think that there can be great benefit in providing options. They're kind of coercive options, right? Go to jail or go to counseling, but there is still a choice there. And determining, okay, the person's going to select counseling, but the impetus for counseling and the important thing with counseling is that it's client driven. So if the client chooses counseling, they then get to choose what their counseling goals are, right? So they can engage with the counselor in a way that makes sense for them. And, you know, here at CMHA, we really advocate for harm reduction, and harm reduction can be anywhere along that spectrum of recovery. It can be abstinence, or it can be just making changes to how an individual uses so that they reduce harm in their life. And that could be harm to themselves or harm to their community, harm to their family, that kind of thing. So I hope that clarifies that a little bit.
I think that process with the diversion programs is that you always provide that choice. And if you never provide the choice, then you really aren't setting up any kind of opportunity. And it can take a lot of asks, a lot of offers before someone accepts as well. But I think the objective is to always ask. The other thing with the recovery approach, you know, you have someone provide someone with the choice of continue to use. It doesn't necessarily mean we need to agree with them and can't express our opinions too, but we don't do it in a judgmental way. We just, you know, there may be a different course of action, but always respecting their choice in the matter.
So there was a reason why I asked, you know, the comparison between, you know, a 3-year jail sentence and counseling, because if it does work and we had our judges giving these people choices and the best choice would be counseling, do we even have the facilities to be able to do that? Or if that person chose counseling, would someone turn around and say, okay, well, we can get you to Guelph or some facility in a year or 2 years? Or do we even have facilities or counseling that they could go to?
Well, we have locally at CMHA, we do have counselors who are court support workers, and we have services available. You know, in terms of our capacity, that capacity is being eroded through. You know, we haven't had those base budget enhancements, so we have to vacancy manage to balance. So it's certainly our capacity is shrinking, but we do offer those services.
Thanks. Naomi, you wanted to jump in there?
Just going to add, we also have our Rapid Access Addiction Medicine Clinic, which has some social workers as well to do the counseling piece, just to hold people until they can go to CMHA to new directions. And of course, we're really hopeful that the Bayview Project will launch. We're trying to call it now the Addictions and Mental Health Project, and that will also have more resources in our community.
Right. Thank you. Okay, I don't see any other questions. Kevin, back to you.
Okay, thanks. And I think this is good. This was structured for a conversation, not so anything that we can do to have a conversation, I think helps. So thank you for the conversation. The next one here, just around mental health, will be Scott and Steph.
All right. Thank you, Kevin. So one of the main goals of SOS is to meet people where they're at and connect them to the services they need. And certainly, we are seeing significant mental health needs within the population being served by SOS. We are encountering people who have or continue to experience trauma, and that is a consistent theme. We're also seeing SMI, such as schizophrenia, bipolar disorder, and mood disorders. So generally what SOS would want to be doing is to connect these individuals to case management to support them with their mental health goals. Unfortunately, we are encountering wait times, or in some cases, the people we're serving are not meeting eligibility criteria. And I can tell you, I know GBHS is taken on many initiatives to help with wait times for services. CMHA is doing the same thing, but you know, we are limited by the resources that we have to manage these wait lists. So what we're seeing is the SOS, rather than being short-term, is having to carry clients and provide case management to them. And in some cases, it's difficult for SOS to pass clients on because they've established a really incredible therapeutic rapport and have been able to help support individuals to meet their goals. And it just wouldn't make sense to pass that person off at that time because the connection has been established. But what we are seeing due to the case management role with SOS is we're seeing unsustainable caseloads, which dilutes the quality of service that we're able to provide. So this is a theme that we're running into. We're looking at getting more resources to support with the sort of short-term case management, also looking at working with our partners to see how we can help resolve the issue of wait times for services. Kim, is that a new hand?
Yeah, go ahead, Kim.
Sorry, Scott, so help me to understand, I was aware of the significant caseload for the SOS counselors. Is the ideal going forward that this work would be more integrated with CMHA's New Directions program, or does this need to be its own track or its own service?
Well, I think the goal for SOS would be to be integrated with the spectrum of supports available within the system. So not just New Directions, but certainly for the folks who have identified addiction counseling as one of their goals, we would want to be connecting them to New Directions. For folks looking for case management, we may refer to GBHS or perhaps outreach within CMHA. So the goal in terms of outreach is to look for the services that meet the needs of the individual, and
yes,
the individual, it's part of their self-directed goals, and minimize the need for the harm reduction counselor within SOS to carry a caseload.
Right. Now, the way that system works currently, do GBHS and New Directions for the clients that come in through that way, are they already working together, or would this be something new or different to more tightly integrate those two things?
Well, I think we're always working, and Naomi, feel free to jump in at any time, because we're always working, CMHA and GBHS, to be as integrated as possible. But what SOS is doing is we're out there encountering people who have traditionally not been connected,
yes,
or have had broken connections with the system. So they're not currently receiving services from any mental health or addictions providers. So, what happens is, we may meet them the first time and they're like, no, we're good. And then the third or fourth time that we encounter them during our rounds, they're like, I feel like I can trust you, and I'm open to talking about, what's going on and some of my needs, and look at being linked to services. So that's generally how the therapeutic relationship forms within SOS. It's not first visit.
No,
it's after multiple encounters that a person is ready to reach out for support.
thank you. And I guess I'll stop now, but at some point, can we talk about how it is that that New Directions can up staff to meet that need? Is this a Ministry of Health conversation or something or somewhere else? And I'll leave it there.
Okay, well, Clark has his hand up, so I'll let him answer your question, and then he can chime in with what he was about to say.
Sure. That is definitely a funding question, and that funding would come from Ontario Health for our purposes. The other thing I just wanted to clarify, if I'm understanding part of your question as well, in terms of SOS, if you mentioned becoming sort of a standalone, I think the strength of SOS is that it is an integrated approach and a collaborative approach. If we broke it off to make it a standalone, I think we'd be falling into the trap of creating silos and moving away from integration. So the strength is in its collaboration and integration, and we want to keep that. So the outreach we do is an extension of what CMHA does. But part of the magic that happened, I think, in Hanover over COVID was everybody brought something to the table, and it was a little messy at first, but everybody stayed to their lane. You know, EMS was visible and on the ground and had the strength and calm in communications and that crisis. We brought the harm reduction and mental health. GVHS brought addiction medicine. Everybody stayed to their lane and everybody collaborated. We started to work as a system. We started to do what we've been talking about for a long, long time. So really, I feel strongly we don't want to create a silo on this. We want to maintain the collaboration and the integration.
I guess if I can, Mr. Chair, my concern is that how people step up in a crisis, and certainly everybody here has done an amazing job of stepping up in a crisis. But when we think about the long-term sustainability of this service, and what Scott just said about your SOS counselors carrying a significant caseload, is that sustainable? And what do we need to do right now to start the work to bring more resources to bear so that this system doesn't break down?
So I think this is, and I know that there are some other OHT planning committee members, I think, listening in, but not on the panel channel. I think this is a conversation for the OHT table, partnership table, when it forms. And the SOS is a prime candidate for a year one project, but it's definitely the type of challenge that the OHT table is structured to deal with and intended to deal with.
So I want to be very clear because we're writing a report with recommendations coming out of this task force. Mm-hmm. So are you what you're saying, Clark, is that the OHT has command of resources that they could decide as a group they wanted to direct? Or are you saying that the OHT, by making a collaborative decision that more resources are required, would jointly request those funds from the province or something else?
So the OHT is in a developmental process. So we're just getting to the starting line of standing that table up. And so initially it doesn't have command over the resources to allocate. It will have staffing resources that it can project management and other staffing resources to provide that support to programs. At maturity, that is the vision of the province, that OHTs will have command over local funding dollars and can, but we're not there yet. We're not at maturity. But yes, in terms of having all the partners at the table, the OHT should and will, I'm hoping having all those partners at the table and signed on, and have a decision-making process to, yes, make recommendations and have a stronger voice with the funders. So.
Will, this sounds like it is an evolution and a longer backtrack. What can happen right now to try and get more resources? Because my sense of it is we don't have years and years to be able to address what we're seeing.
Mhm. So Allison and Naomi have their hands up, so I can let them weigh in.
So just before we go to them, Clark, do you think what we're doing now is sustainable? Like, what are your views on that?
Well, I would defer to Scott. He's closer to and Stephanie. Certainly, the staff are dealing with huge caseloads. I think in terms of the staffing, it's sustainable, but we'd have to make sure we can't meet all the need. We can do what we can do, and we'd have to be clear on that so the staff don't burn out. Because there is more need than we can respond to. I think my impression is that the structure is evolving and strengthening. So we've got a leadership table now, as well as operations table for SOS, and I've learned a lot through the process since that first Hanover crisis. So I think it does have the trajectory is very positive, and we are utilizing some existing resources too. So there's a foundation to build on, definitely.
Okay, I'll go to Stephanie.
Yeah, I was just gonna say that I think one of the things that we really learned through SOS is that our system locally is stretched, right? So we do need to enhance our system. What's been really amazing about SOS is that we've connected with community members who would benefit from support, who weren't previously connected or who had those broken connections. So now we've got an already fairly overloaded mental health addiction social system locally, that now we've tapped into this other whole group of community members who hadn't previously been connected, and their needs are really high. So, you mentioned New Directions. I would argue a lot of the folks that we've been connecting with through SOS wouldn't actually be great candidates for our New Directions services, because a lot of our office-based services require a degree of wellness that the people we're encountering aren't at yet, right? And may never be at. So to a degree, we need to look at, enhancing, housing for sure, but also things like assertive outreach and street level supports. There's a huge housing crisis in the area, but we also have to address that not everybody who currently isn't housed is ready to go into housing. So, that won't be successful either. So how do we support people really where they're at? And I think we need more services in that regard, so that the outreach positions, the case management positions, and all of those people looking at things through that concurrent lens, because so many are experiencing both mental health and addiction concerns. But we can't swoop in and try and save people, because they may not be ready to make those changes, and then it's just more failure, right? I don't know if that helps kind of clarify that, but I think a really big piece of what we learned through SOS is that we're encountering huge gridlocks, right? We need more.
Okay, thanks, Steph. We have lots of hands here. I'll go to Naomi next.
Oh, I echo really what Stephanie said, and as well as what Francesca and Sherry said, that we do need a variety of housing options so that we can provide services where people are at. I do also want to highlight that in our current job market, we're all really, really struggling with staffing. And I think when the positions are temporary, it's just not the market to find temporary employees. So to have a permanent funding source, even be it smaller or larger, is better. But really, to continue SOS, I do feel that we need a little bit a commitment, and hopefully Ontario West can help with that. Because I don't think the OHTs are going to be ready in a timely manner to be able to move this project forward the way it needs to. And again, just really reinforcing staffing is difficult when you have temporary positions in particular.
Allison?
In response to Kim's comment about, being clear about what we want to put in the recommendations, I just needed to get this in. From my view, in Grey Bruce, we have a deficit of peer support workers. If you look in communities and surrounding communities, you would see a peer support worker embedded in every health and social service, not just in mental health and addictions. So a peer support worker is someone with lived experience who can connect and build trust and support people along their journey without, having the expertise in terms of education. They have the expertise in their own lived experience and how to navigate that. And it's really something that we need to put resources into locally. I think if you ask the manager at peer support at CMHA, they would tell you the same thing, that we would love to see more resources put into peer support. And, that they need to be embedded across the system, as well as in policy and planning. And I do just want to mention that the next presentation is from the Peer Advisory Committee. So I just need to put that plug in, and that some of the answers to these questions might come through in that presentation. I also just wanted to check on the timing in the agenda of when we might expect. So just kind of looking at the agenda and the timing when we might expect that presentation to move forward. Thank you.
Kim, did you want to speak to that?
I think we have a little bit left of this current presentation, and then we'll be wrapping up that discussion. So I don't know, Kevin, what are we, another 15 minutes maybe? I don't want to cut off the conversation because I think we're uncovering some important information here. But the peer support group is up next, Allison.
Yeah, and some of the stuff we've been discussing will come up in the future slides as well. So we can it's all kind of working together here anyways.
Okay, just before we move on, I just want to get to Dr. Zayed.
Thank you, Mr. Chair. I just want to add a very quick note here about the resources. The evaluation that public health is using or developed for this particular project is really very important. I have discussed with our program evaluation coordinator some very important point about allocation of resources. We'd be happy to present some sort of presentation also about the allocation of resources to the panel here.
Okay, thank you. Kevin, carry on.
Okay. We've already covered addictions treatment, but I just wanted to check with Heather, with you being the frontline nurse practitioner, would like to say anything about this treatment, what we're seeing?
I think Robin and Dr. Cox did a great job explaining our recovery model and the different therapies available. I can answer any other questions that may have come up from that.
Okay, thanks. Next is just the importance of primary care, and Heather being the nurse practitioner, she'll speak to that. And also,
I think we covered some of that as well. I think the first question that came up is, would these folks attend to the ER? Does the service already exist in another venue? And I think the answer to that question is no. Very few of these folks are able to attend traditional appointments, fixed times, transportation difficulties, competing survival needs that are often having to be put ahead of primary health care. So being able to attend to folks where they're at, being able to fill that gap. We obviously do have a very significant shortage of primary care providers, and especially those willing to take on individuals without fixed address or phone numbers, or with concurrent disorders, certainly a challenge. So it has been really lovely to be able to manage episodic illness, chronic disease management, vaccination, individuals with Hep C, screening for HIV and STIs, and referrals to specialists for those who are not able to access the system by traditional means.
And what we're finding is the community paramedic working with the nurse practitioner, we're like an extender of that nurse practitioner. So even if the nurse practitioner isn't with us, she's able to delegate to the community paramedics and offer that care out in the community. So it's just been a really excellent partnership. And then also, again, we learn from each other all the time. The next one here, supportive housing. And I just want to say up front around housing, we actually are terming this health housing. And I can't say enough of the support that we've gotten from Grey County Housing. I've walked down the hall numerous times for, just asking if they can help us, and they've always been there for us. This is not about them not offering housing. This is a certain type of housing that we require, and that I don't believe exists right now. So I'll let Scott and Heather Morris speak to it though.
Thanks, Kevin. So several times throughout this presentation, housing crisis has been raised. We currently do have a housing crisis. It's been around for a while. It's certainly been exacerbated by the pandemic, in the increased housing market, as well as the increase in rental amounts. So it's made an already bad situation worse. There's certainly a need, despite all of the amazing work that's being done, for more affordable housing, attainable housing for people who don't have the resources to be able to participate in the current competitive rental market. But also what we're seeing is the need for more housing with supports. We currently do have such housing within the system, but the level of support available is not enough to meet the needs of the population SOS is encountering, and in many cases, the needs of folks who are currently on the by names list, who are moving into housing, but without the appropriate supports, ultimately may not be able to maintain their housing for a variety of reasons, including mental health needs not being met, home takeover, behaviors associated with substance use, and just not having the life skills required to maintain housing. Life skills we're seeing as a big barrier to people being able to be successfully housed. So I think what we need is housing with a high level of support available for individuals that we are seeing. I do personally believe that for the highest need individuals, we need 24-hour supportive housing. So there are supports available on site 24 hours a day, 7 days a week, to meet the needs of people when they need the support. People don't go into crisis Monday to Friday, 9 to 5. Somebody may need supports at 2 in the morning. So I do believe that is a huge gap in our system right now. That I think as a committee, we need to look at filling. We also need housing that is able to support people who are on OAT or maybe using substances, recognizing that supportive housing, this is still a person's home, and they do have the same rights as a tenant would under the Landlord and Tenant Act. And of course, Grey County has the 14th Street building that they're looking to set up short-term transitional housing. That's having a building is always step one. Having the supports is another requirement to make supportive housing projects successful. I see Kim has her hand up. We are currently looking at a model of support for 14th Street. But even once we come up with a model that we feel will be effective for the population served, we will need to find funding for the resources to support that project.
Kim, go ahead.
Thanks so much. And Scott, just for the record, can you tell the task force how is supportive housing normally funded? Where do the dollars come from to pay for those staff, or what in the places where this kind of housing exists? Who, in your experience, has had responsibility for running it?
Yeah, in my experience, and I've worked in mental health and addiction supportive housing for a number of years prior to coming to Grey County. It has been Ministry of Health funded.
Okay, and who is Ministry of Health providing that funding to?
In my experience, I previously worked for a community mental health and addictions nonprofit organization. And we were provided with the funding to provide support, sometimes in buildings we owned, and other times it would be municipal housing. There are a number of ways that supportive housing can be arranged.
Wonderful, thank you.
You're welcome.
I think Heather was just going to speak to about the importance when we start somebody on opioid addictions therapy, what it's like, we really need them in a place that we can see them and treat them. And then what happens when they actually get into secure housing, the importance of maintaining that treatment so we don't lose all the work that we just did.
Absolutely. I think the rooming house fire was a really great example of how our very limited human health resources was able to serve 49 folks in one space because they had their street family, their social connection. And after the fire, folks being dispersed across the county for various reasons, continuing, restarting, monitoring their opiate agonist therapy became very, very challenging, as we're only a small group of folks to go out and assess. Being 15 plus kilometers from a pharmacy where you're supposed to eyes on dose every day, a lot of folks fell off for a period of time. For those who have been able to secure some more stable housing and able to put their health higher on their needs, finally, we've had some beautiful successes in the last 3 weeks of people really making an astounding shift to abstinence when that was not the recovery goal pre-fire. So I definitely want to echo what Scott said about how important the intensivity of the supports that are needed for some of these folks who would be considered not housing ready, maybe want to continue to use, and then are not able to qualify for currently available services, but have very, very evident need.
Thanks, Heather.
Next is the situation we're seeing a significant amount of is human trafficking. I remember myself, 3 or 4 years ago, the police put on a presentation about human trafficking here in Grey County. And I thought to myself, why would they do that here? We don't have that problem. And that me in the industry I'm in, you'd think I'd know about it. And I didn't know about it. And I didn't really know about it until SOS. And we just feel it's important that we bring this forward. So Steph and Heather.
Yeah, so something that we've seen throughout SOS is quite a high prevalence of situations where individuals are being trafficked. I tried to speak with Felicia, who's our SOS harm reduction counselor, who's been supporting most of the women, because it has typically been women that we've been seeing involved in this, how many encounters she's had. So since February, she guessed between 10 and 12 women who were victims of human trafficking in Grey and Bruce. So those are just the ones that she's encountered, and those are just the ones that have felt safe enough to disclose that was happening. So it's a alarmingly high number. in our small community. It's very real, very scary, and it requires a very specialized approach. You know, the knee-jerk reaction can be to rescue and just get that person to safety. That response can be quite dangerous. These are individuals who have been, you know, the victims of human trafficking are heavily controlled and they are at high risk of violence. And so we need to approach the situations delicately, and really focus on going slow, building that therapeutic rapport, building trust, and just really walking alongside the person so that when they feel safe and when they feel that they can take a step away, we can act quickly to get that person to safety. So in a lot of cases, the individuals are using substances, whether by their own choice initially or not. Substance use is prevalent. There's a lack of safe and affordable housing options. You know, even when we look at taking, say a woman discloses that she's being trafficked and she wants to go somewhere safe, say she's an IV drug user, and now we're going to try and relocate her to the women's shelter locally. Well, she can't continue to use substances while she's at the women's shelter, which makes sense because that's a home for people. And but it creates a barrier. So where does this woman go for safety, right? Where do we make sure that she can be housed safely? And we're not going to just suddenly pull her only coping strategy away from her in this time of crisis, right? Because when you look at why somebody might be using, say, an opiate when they're living through this degree of extreme trauma day by day, there's probably a pretty good reason why they're numbing. So we're not going to just take away their medicine in a lot of ways, right? So very complicated. We've had some great successes around this, however, and I'm sure that we will continue to see women and possibly some men who are in this situation, but very limited resources.
So Stephanie, I'm a little bit shocked at this. These girls are controlled by who, and where do the police come in on this?
Yeah, so they're controlled by, sometimes it's a partner. I'm going to air quote that. Sometimes it's by, what we would call a pimp. We do know that there are drops that happen. So women get brought to the area. This is very common with women who are being trafficked, is they're not from here. They get dropped here. They get kind of connected with another group of like handlers, and they get moved through the community and then moved on again. They're heavily controlled. So they won't have access to their own identification. They won't have access to a telephone. They won't have access to money. Possibly not even their clothes. So we have to be incredibly cautious. You know, this came up early days of SOS. We can't just be doing cold calls to certain women that we're connecting with, because it might not be safe for us to show up unannounced if their handler, pimp, whoever isn't expecting that visit. Then that can suddenly put that woman at great risk of violence. So who are these people who are controlling them? I don't know. When we encounter women who are being trafficked and they disclose that, we, work with them to encourage them to connect with the police, but that's their choice, right? These are individuals who have had all of their power, all of their choice taken away from them. So we don't presume to know what they need. They get to have that power back, and they get to determine the next steps that they take.
So you're saying in most cases the police don't get involved?
Not always. Not always. We've supported several women to get into treatment outside of the area, whether that be for substance use, because again, the bulk of the women we're supporting in this way had serious substance use disorders, but also to safe housing outside of the area as well. So along their journey of recovery, they may decide to connect with police, but it's so complicated and it's so dangerous that going to the police is not always the safest route for them, unfortunately. And it can then endanger family and loved ones, depending on what kind of leverage they have over people.
Okay, I'm just going to go to Dr. Zaya.
Thank you. I just want to comment on this issue. It's really a serious issue. We observed these cases during the forum outbreaks, and we started to have some of the women who were living there coming to our case contact management during the outbreak, and we put them into the shelter and we tried to help them. And so the human trafficking, there was some committee before, and it was just not meeting again or not sustainable at certain time some years back. So we are working on putting this committee back, and one of our social determinant of health nurse, in addition to the foundation standard manager, are working again to have some partnership from the community so that we can have some raising awareness, putting some kind of ideas and planning for that as a social phenomenon. The other social phenomenon that we noticed also is home takeovers, and again, public health is leading work on that, in addition to community partners like the police. And it's also a secondary situation based like due to the drug addiction. So there is more work is coming around these two social phenomena.
Okay, thank you. Kevin.
Okay, thanks. So the next is importance of street outreach, and Steph and Heather are going to speak to this.
Yeah, I think, we've touched on this quite a bit already. I think the important piece here is that the clients that the team is encountering are folks who are not currently, for the most part, engaged with our health and social services for a whole slew of reasons. So we go slow, and there needs to be time to build that rapport. This is not a quick business, I guess. There needs to be time to develop that therapeutic rapport, to build trust, because there's been no trust, and to help empower people. We need to, work alongside individuals and really listen and get an idea of what they're looking for in terms of support, because we can come in from our very privileged perspectives and identify what we see as problems and think, okay, we're going to focus on this today. We're going to get you, OAT, and we're going to get you, new clothes, and we're going to do whatever. But they may not want that, right? And taking away that choice just further disempowers people. So really listening to what somebody wants and needs in that moment helps to build that rapport, helps to foster hope. Choice is so critical, and building that trust. This really ties in with that harm reduction approach, which is what the approach that the team takes, right? So again, not pushing our own agenda, and not saying, hey, I see that you're using drugs, that you're using them by IV. Let's get you to stop that. Instead, it's a conversation around, hey, I see you're using drugs and you use intravenously. Do you use new equipment every time? And then having a conversation around, why that's important, and then ensuring that they have access to new needles every time they use, and explaining, that how that can stop the spread of disease, and that can limit or lower the chances of abscesses. So it's not a conversation about forcing our opinion on whether that person should or shouldn't be using drugs, but how can we do that in a safer way? And I think that's really important to build that trust, and then can help support people with that system navigation. So we might see someone again who we're like, okay, this person needs an intensive case manager, and we might jump to making that referral, but the person might not want that level of support, right? So we have to, again, meet them there to say, okay, no, they don't want a worker, they just want access to, safe and sound, or they want to pop into OShare. Yeah. Anyways, Heather, I don't know if you want to say anything else about that.
Yeah, maybe just really briefly. I think we've talked about it quite a bit. But you know that when we have that shared recognition of someone's real circumstances, and we honor them for who they are and where they're at. If they're not ready for service, you know, if that one connection, that one opportunity to be received in a non-judgmental, compassionate way, you know, I really feel that they're going to value that, they're going to respect that, and are more likely to work with us in partnership in the future, and hopefully soften the system in a way that makes them more likely to reach out for service in the traditional means or by us meeting them where they are.
Mm-hmm. Yeah, I think that going slow, consistency, demonstrating follow through. You know, you think about a lot of the clients that the SOS team is engaging with. These are people who've often been connected with the system since a very young age, right? They may be people who've been involved with the child welfare system right from, youth through adolescence, and there's a distrust at times. So you have to slowly rebuild that trust. And we do that through actions and through listening and following their goals and their wishes.
I've had the privilege to work with this team, a year, but the SOS since February. And what I find with the team that makes them so successful is that if somebody misses an appointment, they go find them. They don't say, oh, you missed your appointment, or you didn't check in, that, you mustn't be ready. I hear people sometimes, and again, I'm just going to say it, that, they're just out there partying. If you actually spent some time with this population, it isn't much of a party. They're using substances. Yes, they are. But if you've seen the way they look and their health and how that suffers, this is not a party, far from it. And, having those people that will get out from behind the desk and meet them on the street, meet them where they're at, as far as system navigation and access and care, some of them, they don't function. They're up most of the night. They're not coming to a 9 o'clock appointment. They're not coming to a 10 o'clock appointment. To tell you the truth, they may not even remember they have an appointment. They need people to remember that they have an appointment and check in on them. And as they get better and they get healthier, we see it. We actually see them now messaging us. We're actually talking about this yesterday. We have people messaging us now saying, I got this change tomorrow, but they're so sick. And I think we have to look at people as if they're sick. They're sick that they don't know that they're sick. And we need to walk alongside them. I don't care if you pave the system with gold. They're not coming. If we're not going out to reach out to them and hold their hand and walk beside them, they're probably not going to come. And that's so important about street outreach. I can't say enough about the team. I think we need more of it. I think we need training. I think safety is a barrier. Sometimes people may not want to do it because they're not exposed to it, but I think that's a real gap.
I just want to build on something you said there quickly, Kevin. A lot of people think that, individuals who use drugs are out partying and that, they might be up all night so they can't make it to a 9 a.m. meeting. But I would, why are they up all night? They're up all night because it's not safe to go to sleep, right? So they're not up all night partying. They're up all night because if they fall asleep, their things might get stolen because they're living rough, where, they might get sexually assaulted if they go to sleep. So they're staying awake as much as they can to protect themselves. It's a survival technique. And I think that's important to pay attention to.
Okay, bottleneck of traditional services, Heather and Scott. Sorry, it's just taking more time, but we just wanted to make sure we get through this.
Just to jump in as well. I think it's important. Often when we talk about addictions and people with substance use disorders, there can be a sense of them and us as well. And I just think it's really important that everybody understand that everybody is vulnerable to this. Everybody is vulnerable to trauma, and anybody could fall into a substance use disorder. Because what the substance does is alleviate temporarily that negative effect of the trauma, and then you go back to it and you go back to it. So again, it's Gabor Mate's line, ask not why the addiction, ask why the pain. So I think this is an important point in terms of the education, but because to break through to the public, we have to break through to them that, you know, these are not other, these are us. These people are us. They are brothers, sisters, you know, parents, children, and they are just like you and me. There's nothing different about them. They've experienced trauma just like we can.
So Kevin, I think we've talked a lot about, you know, waitlist for services, the challenges that presents to SOS and the folks who require services, as well as in some cases what people need just doesn't currently exist, or the services that do exist, they may not meet eligibility requirements for those services and therefore cannot access the support that they need. So in the interest of time, I think we've driven that message home throughout the presentation. So
sure. I just want Heather to maybe say one because we countered.
Oh, sorry, Heather. Sorry, Heather.
It's just around access to drugs like Sublocade and funding for it, because I don't, short of me laying out my credit card sometimes, I'm not sure sometimes how we get this, and not that we've done it, but it's been close. You know,
yeah, you're right. So from a medical standpoint, we do still continue to struggle with some individuals who, when they are ready, don't have the things they need to action some of these recovery goals. For example, would be an individual who has assets, but has no access to those assets due to divorce, legal matters, then can't get OW. Without OW, you can't get a drug card. You can't get a drug card, you can't afford Sublocade. It's a fantastic medication, but it's over $600 a pop. So some of those things take a significant amount of effort, time, applications, and our integrated system. So and being able to break down some of these silos and work in a more team format has already improved some of those access points, but they certainly still are a bottleneck. They do take some time. RAM is wonderful. RAM does have a wait time of approximately 3 to 4 weeks frequently right now. So sometimes we're able to bridge as the SOS team. But those without a fixed address, those without a telephone, I can't get home care involved. Specialists can't call the individuals to set up their appointments. It comes back to that supporting housing, that intensive case management piece to help an individual get where they need to go to be well when they're ready.
Could I jump in just one thing? This is slightly off track, but I think an important point. In terms of recommendations, if you wanted to plant a seed that maybe for the longer term is the real need to incorporate addiction medicine into all primary care practices. I think the stat was only 9% of primary care practitioners asked their patients whether about substance use. So it really is important in the long term that we incorporate this into every the basic offering of primary care practitioners, and certainly I think the RAM Clinic has that as an objective, but we need to support that.
It's Francesca. I'm just going to jump in on that because one of the issues around accessing withdrawal management is what pharmacies are able to dispense. So there's nowhere up the peninsula. So we might be able to find somebody housing, but if that pharmacy in that community is not providing it, and suddenly we need volunteers and gas cards to drive them, once or twice a day into Owen Sound, that becomes a barrier as well.
Thank you, Francesca. That's a great point.
Yeah, next slide, just around best practice guidance. And again, I think that we have and are so fortunate to have the amount of experts that come to the table around this and our partnerships. It seems at times, especially when we're bringing, the health and the social support and the housing together, and really the missing link around the health, housing, those types of things. And what do we need in this area? More discussion, safe use, safe supply. What are those options? What would that look like? As far as a shelter. Do we need a shelter here? Is that something that we should look at other communities, what they're doing? We've had discussions with Toronto and London, even though they're urban, but what does it look like in rural Ontario? I think that there's work to do in this area. I to tell you the truth, I think it's a largely provincial and local problem. But at the provincial level, if we bring services, speaking to a friend of mine in Toronto that works in this area, you build it, people will come. maybe every community needs this type of these services because they don't right now. Maybe they need to be forced to have it so that if we build a place for 50 people, they don't all come here. Maybe everybody should have one in their community, but that's provincially directed. Again, I just think that we, as much as we have experts, I think there's some still work around best practice guidance. And next is just we're going to do a couple short scenarios just to give you an idea of what we're doing and what we're seeing out there.
Yeah, a few of them have been brought up as we went, so I think I'll choose one. And I think what Clark was saying about how we're all vulnerable to this issue. One of my recent clients was a champion athlete, prescribed opiates from a primary care provider, and that primary care provider thought they were doing the right thing by the patient by cutting them off and firing them when they needed to use more than was prescribed. So this individual was left in a situation without a primary care provider and needing to use the street to access prescription medication, which has led to an opiate use disorder with fentanyl. So this individual, when I met them, had a very, very negative feeling about the medical system and about primary care and a stigma attached to her situation. And, I began that situation by first apologizing because, the health system, the physicians, primary care providers, we have caused so much of this problem. Again, this is not a party drug. Very, very frequently people are suffering either in very actual physical pain, suffering from trauma, undiagnosed concurrent disorders. There's so many reasons why people are choosing to numb, to soothe with substance. So in this case, it's gone great. We've been able to reach Sauble, to go all the way out to Sauble where there is no access to RAM Clinic currently, and serve them right from the bus. And it's going beautifully. But I think that was a really good case to show that it can happen to anybody. And likewise, I wanted to share another case, an individual who we have been struggling to serve. Again, someone who has, we do have a women's shelter. The women's shelter is full. We have very few places to take folks right now. So if you have been a victim of domestic violence right now, that violence needs to be very, very recent to even qualify to get in right now. So that's one of the areas where we're experiencing a bottleneck where people are in great, great need for service and there's just not enough places to go. So people who would traditionally leave and not need that intensive care are in so many levels of our intense care that we're just stuck. There's no place for well people to move to right now. And this individual, because they've been so displaced, has not been able to stay on OAT in and out of our care. Currently housed, and again, pretty much thanks to Kevin and really pushing, here's my credit card. There's times where there's just the system doesn't fit. And doing our very, very best to be ready when she is ready to stop, but understanding that there's a wide amount of trauma. There is sex trafficking in this situation. And sex housing is also something that I think it's important to mention. There's folks that in order to remain housed, do perform sexual favors, do partner, let's use those bunny ears again, for the safety of being housed. Is it consensual, right? Or people have to be ready to leave those situations and accept other help. But that is a very, very slow process in helping individuals leave those situations. But it's been so lovely to be there, but we don't always have a next place for them to go, which is really, really unfortunate.
Steph, did you want to bring up a scenario or do you want to just?
I think maybe for sake of time, we'll just keep moving.
Okay. Right. So just around some asks, to tell you the truth, I never thought I'd get to a place where I was a week ago in paramedicine. Like we're always coming, no matter what the weather, what the circumstance, we're always going to come. And that's kind of way, when I work with the team, I bring that forward to them. And to tell you the truth, I had to change my focus and I'm not happy about it. And, but I have. That we actually have to say that we've done all we can do. And I didn't think I'd ever say that. And I've had to have the team leave some very complex and scary situations of people that we had nothing else. And to tell you the truth, that sucks. Sucks for the team. It sucks for the person. The system, to tell you the truth, sucks. Lots of gaps. So I think there's significant investment required. like again, this back to this health housing. And again, it's really around that health side of things. Thank you so much for the county support for the housing that they do give us. We need more mental health and addiction support. You know, we need more street outreach. You know, we need to get out from behind the desk. Before COVID hit, actually, I remember the discussion I had with Ian Wright at Public Health, the next opioid meeting, I said we should go have it at Tim Hortons downtown Owen Sound and talk to people. We need to get out from behind the desk. We need local support for the SOS model. When we first went into this, we thought we'd be out seeing people and, you know, case finding and getting people connected to services. And we have, but then there's nowhere for people to go. Now we're holding on to them. We're going to add another mental health counselor. We're going to do things, but really we're getting gridlocked. And it's not only tough for the person, it's tough for the team. And it really causes pressure on the team and really affects their mental health. And we feel for them for that. I think we need provincial advocacy for change and resources. Again, these are our asks and considerations, and they're big. I know, but we need to look at this, and it's not just here; it's across the province. No matter you're in the big cities or these small areas, we all face it. And to tell you the truth, just because you're not looking for it doesn't mean it's not happening. I've seen that too, where people say, "Well, it's not here." Well, have you looked for it? Because it probably is. You're just not looking for it. The last year, again, I can't say enough about the partners. What made this all successful and still continues to be successful is our partnership, recognizing that health isn't primary. It's about supporting our clients, our friends that, you know, are struggling out there. And, you know, like we have to be able to provide those social supports, the housing, and then health discussions will come. But without having those supports, it's not possible. I bring back to the fire that happened in Hanover. I got the call probably shortly after 4 o'clock in the morning. And by 5:36, the church was open. Colleen at O'Share was on her way down with coffee and food. You know, Graber Self Service, CMHA, you know, they were on the way with nurse practitioners, mental health supports, our community paramedics were coming in. You know, we had different agencies, housing, social services, you know, nurse practitioners were on the way. By 9 o'clock, like 3 to 4 hours, we had a full shelter set up. You know, we should be proud of that, you know, the partnerships that were done and how we handled it. And I think it just goes to show that this needs to be a partnership, you know, to help the people. It's a very complex situation. I'm, to tell you the truth, so proud of everybody that's a part of this, the work that they've done. It's quite phenomenal. Again, I'm just really appreciative for everybody taking the time and share the story today.
Thanks, Kevin. And boy, we have a long list there. Thanks to everyone that spoke through this presentation. That a little bit longer than we had expected, but that's okay. It was important and very well done, Kevin. Appreciate it so much. Because of time, I think we will move on to number 4 next with Sandra McClay Winters, Peer Advisory Group. Items 5 and 6 in the agenda, we're going to move to another meeting just because of the time. So Sandra McClay, you're up. You have the floor.
Thank you, Chair O'Leary, councillors and members of the task force. Tara, can you bring up the PowerPoint?
Yes, I will.
As Tara's bringing that up, I'll just say that it's an honor that I represent the Peer Advisory Committee. Today, the Grey Bruce Community Drug and Alcohol Strategy resources the Peer Advisory Committee through funding from Grey and Bruce counties. Can you proceed to the next slide, Tara? As a committee, we're a group of passionate individuals who have lived experience with substance use, and with this experience, provide honest feedback to service providers in the area. So my presentation today will be from a very different lens than what other presentations have been. Every one of us on the committee has experienced the impacts of substance use. Each of our experiences unique to circumstance. Tara, can you go to the next slide, please? In preparation of the presentation today, the committee members were asked to speak of times when they felt empowered and times when disempowerment was experienced, and how that experience could have been different from that for them. I am very humbled to present the following video in which the members of the Peer Advisory Committee courageously share their stories of challenges and successes that they have experienced while navigating services within our community. I will advise that the subject content may be triggering for some viewers as it does relate to substance use, mental health, self-harm, suicide, death, and dying. Tara, if you can start the video, please.
Rob from our communications team will be playing that for us.
Once I was denied service when I was at the beginning of a downward spiral and reached out to a local agency for support. I don't recall the justification for the refusal, just that I felt abandoned, terrified, and without hope. If you're in extreme crisis, you will try to find a way to manage your pain. Without anyone to talk to, I went deeper and deeper into substance use. I lost my job, got evicted from my apartment, started stealing in order to eat, and got into some very dangerous situations. Eventually, I wound up in the emergency room at the hospital. This has got to be one of the worst ways to find support. It was lacking in compassion and understanding, and it sent me down many useless avenues that aggravated my mental health state, worsening and prolonging my condition. I want you to consider for a moment how much courage it takes to reach out and ask for help. No one wants to admit that they have a problem they can't handle. So if someone presents saying they're in a crisis, believe them. I consider myself lucky because missing this opportunity can have fatal consequences.
Disempowerment definitely came with any number of service providers. Every time I heard I had to wait, repeatedly put on a waiting list where you were expected to struggle through on your own until someone could fit you in. It didn't seem to matter that I was being proactive about my health. Unless you're in an immediate crisis of harming yourself or others, then you were not a priority. It left me feeling even more isolated and alone and desperate enough to think and plan suicide, either as a way to get help if I survived or just to be done with it all. Somehow there needs to be a switch in our system to prevention instead of reaction, rescuing people from the fire instead of stopping the fire from starting. At the very least, if someone has to wait, leave them with a bucket of water and a fire extinguisher.
I was offered diversion for a criminal theft charge. The process involved writing an apology letter to the store I had stolen from, to the city, and to myself. I felt so full of shame in the basement of the courthouse writing these letters in my nicest clothes. The lady assigned to my case not only showed no judgment, but went out of her way to make me feel valuable and worthy. I remember her kind words often. You are as important as the sun, the moon, the stars. You are no less important than any of those things. It was so unexpected and surreal at the time, but her compassion is the reason I now work in the social work field.
In February, a myriad of events took place outside of my control. I'm stressed, and my family doctor prescribes medication. I take the medication and I have a rest on the couch. It really knocked me out. In April, I go to Kelowna, BC for a sister's family visit. My sisters don't think I should be taking medication and they take from me. I get a very stressful phone call while I'm still with sisters and I return home. Our daughter comes to visit us early May. I'm just not right, but I don't know what's wrong. I'm having trouble making decisions. I tell my daughter something's wrong, but I just can't say what. She is pregnant and due any time. Long story short, but things are getting worse and I'm not myself. Late May, I try to grocery shop and I find myself in the store not sure what to do. I drive home, I tell my husband I couldn't shop and something's wrong. I drive myself to the emergency department. It's hard to describe what's going on and I'm sent home. Saturday, I go back, same scenario. It's getting worse, I'm pacing and I can't function. Sunday, my husband goes with me. I'm told to see my family doctor Monday. Monday, my family doctor prescribes medication. It's too late. My thoughts are out of control. Wednesday, my husband says, "Aren't you coming downstairs for breakfast?" I said, "Yes, I'll be down." I get a glass of water, I open the medication, and one by one, count as I swallow 11 of them. My husband found me and took me to the emergency department. From there to psychiatry. My family doctor came in next morning. I was coming out of the washroom. I'll never forget the look on her face. It was as if I did something to her. Never said a word, and she left. At the time, I was too sick, and I didn't really know what had happened to me. I went to the Emerge 3 days in a row, and I was sent home each time. In conclusion, if I had been admitted to hospital for observation, would I have been prevented from taking the medication that may have resulted in a far worse outcome?
It's hour one and a matter of life or death. I asked the police to help me locate James. He is in a depressive state, further complicated by substance use, not taking his prescribed antidepressant and antipsychotic medications, and has texted me his final goodbye. I am devastated and reduced to tears when an officer dismisses my plea after hearing James's name. But a glimmer of hope returns when a second officer approaches and says, "We will search for James." In the 4th hour, James is found, but unbelievably the officers openly debate whether he is at risk of harming himself or just another lost addict. James is agitated and disrespectful, heightened by his drug use. I want James formed under the Mental Health Act for his own safety. Eventually, a handcuffed James is transported to the hospital. At the hospital, I tell of the events leading up to James's current visit to the ER and see the nurse roll her eyes as I'm recounting the last few hours. Again, I feel James's situation is being discounted. However, with the caring approach, the ER physician listens and acknowledges the situation and arranges to have a crisis worker attend. Hours pass, and in the 11th hour, the crisis worker visits. James is not engaged with the worker at all, as the aftermath of his substance use is now apparent. The crisis worker is less than interested in listening to me. The ordeal is taking a toll. Only minutes into the visit, the crisis worker suggests that James does not need to be admitted because he uses drugs. I beg the crisis worker to admit James and go as far as asking if responsibility will be accepted if James dies by suicide. The crisis worker leaves. I am hurt that James is only being seen as someone that uses drugs. But moments later, the ER physician tells us James will be admitted for psychiatric assessment. He sees my teary relief and gives my shoulder a gentle squeeze. James is on a psychiatric unit in the care of a wonderful psychiatrist for 17 days. The psychiatrist's gentle approach empowers James and gives him hope for a better tomorrow. On day 18, James hugs and thanks me for fighting for his life. The fight was not easy. It was a gut-wrenching roller coaster ride, but oh so worth it for that hug. Regardless of position or stature, no acts of kindness and caring, no matter how small, are ever wasted.
Without a doubt, the time I felt most empowered was when I was connected to peer support. It was the first time I can remember someone telling me that how I felt mattered. My feelings and perceptions were valid, and that being emotional did not mean that I was carrying around a giant weakness. I was paired with someone who had very similar life struggles. Up until then, it seemed like I was on my own. After our conversations, I had the strength to get through until we talked again, which could be the next day or the next week. It gave me hope that I could take the next steps to finding balance in the world and within myself, and that I might someday feel like a whole person.
Richard was in a no-fault car accident. The orthopedic surgeon wrote a letter to the family doctor stating that Richard was a good candidate for medical marijuana to relieve pain. Family doctor said no because Richard had used marijuana in the past. The family doctor prescribed a 10 milligram daily dose of morphine. As a worried mom, I went to talk to the family doctor, who said Richard has real pain. Richard and I were hoping doctor would prescribe medical marijuana, which is used to treat pain. I told family doctor that I had read about the risk for morphine abuse and addiction and the need for more over time. Family doctor's response was, I will not increase dose as long as I'm Richard's doctor. After a period of time had elapsed, the 10 mil was not enough and the patient-doctor relationship ended. The doctor called me to say sorry. Richard became addicted to opioids and has since died of a fentanyl overdose. I often wonder if my concerns had been acknowledged and addressed, would Richard be alive today?
I felt empowered by a few different individuals at different agencies. The ones that go above and beyond what they are paid to do. The ones that truly show they respect you and care about your well-being. The ones that show you they are committed to helping you along your journey. Ones with lived experience is also very important. Nobody wants to hear a scripted chat from a quote professional. Go beyond your training and your experiences. Put yourself in the person's shoes and truly try to look at things with a trauma-informed lens. Show people that these professionals truly care.
I was sober again after a recent relapse. I was staying with my parents and had lost everything, again. I knew what I needed to do. I'd done this before, so I reached out for help. I tried multiple avenues to get counseling and was repeatedly turned away. One organization couldn't offer me services because I had too much sobriety. Another denied me services because I had disclosed my addiction issues. I felt rejected and beyond aid. This has happened to me often over the years. For example, a doctor would be invested in my story and showed interest in supporting me until I mentioned drugs. Their whole demeanor changed. It was like because I had substance use in my history, I was beyond mental health care. Treatment of the whole person is a necessity.
I saw an area therapist off and on over a period of a few years, sometimes during periods of crisis and also in relative stability. Once, after an extreme mental health crisis involving substances, she made a casual observation that changed my life. She noticed that every time my life went out of control, that drugs and alcohol were present in the mix. Up until that point, I compartmentalized these problems. As soon as she made the comment, I had to agree that it was true. I came to see how, for me, poor mental health and substance use went hand in hand. This moment happened long before I made the decision to choose a sober life. But once I heard that very simple, clear observation, I could not unhear it. Its truth became a signpost that I could not deny. Time is such an important factor. It took time for her to observe me in different life circumstances, and it took time for me to develop trust with my therapist in order to hear the truth. It was also the way that she said it that made a real difference. It wasn't like she was delivering a verdict with instructions about how I had to act. It was almost as if it were dawning on her for the first time. There was gentleness and curiosity about the way she said it, so it was easier for me to make the realization along with her. Today, I've been sober for over 8 years. I'm happy to say I've learned to make decisions that serve me better, even in the face of difficulty. I'm very grateful for the work I did with a professional therapist to gain this insight. It keeps transforming my life in profoundly positive ways.
This video offers the opportunity to hear our voices, those with lived experience. Each story shared captures only a chapter in our journeys. Tara, if you can bring up the PowerPoint again and slide 3. Engaging individuals with lived experience when developing, implementing, and evaluating programs is invaluable and has countless benefits. We are the ones in the best position to talk about our reality and find answers adapted to our needs. We are resourceful and have strengths and assets that must be acknowledged in human service and policymaking. We can offer local solutions and are aware of what would work in our communities. Our participation can make programs more adaptable and relevant and accepted by the community. Yet our voices, the people of lived experience, are traditionally missing from the planning, program, and policy development processes. Political and strategic advocacy for improving mental health and addiction outcomes is needed, but this cannot be done without advocacy at the grassroots level. This can start with you in asking the question, what actions have I taken at a personal level, a program level, or an organizational level to work with and listen to the affected individuals in my community? Tara, can you go to the next slide, please? We welcome and extend the invitation to all service providers and government bodies to consult with us, an invested group with the goal of improvement to the challenges faced by the service user. You can also find more information, including best practices and guidance tools, on the Community Drug and Alcohol Strategy website, www.drugstrategy.org, or by contacting Allison Govier, the project manager. I would like to thank you for your time this morning and welcome any questions.
Well, that was a wake-up call. If that doesn't pull at your heartstrings, then you're not human. Thanks for that, Sandra. I don't know, like the stories of being turned away and bad advice, is there a balance to that? I don't know. Clark, do you want to speak to that, or Naomi?
I believe Naomi had to drop off for another meeting, but you know, I think those are very real stories. It's an ongoing endeavor to educate and to maintain a level of understanding on with the issues that people face. And for me, it goes back to that basic point that we need to understand that those who have substance use issues and mental health issues are not other. They are us. We are all vulnerable, because I feel underlying some of those stories are really a sense of that these individuals don't have value, so they're dismissed. So it's not worth the system's time to put they're just another addict. That says volumes. They're not a human being, they're just an addict. So it is it's a lot of work. It's an uphill climb, and I think there are good news stories. We also heard stories in there of great kindness and empathic work. And I like to say, I think we have wonderful workers in CMHJ and GBHS and around Grey Bruce that do provide that service. But there's always need for continuing education. It's because some tragic things can happen. I had a committee member up in Timmins whose son lived with schizophrenia, and he had gone down into the States, and he was tragically shot because people didn't understand his behavior, and it was it can really go sideways. But
And Allison, what are we missing here? Like if these are real stories, it's not like we can deny them, because that's the strength of having people from a peer group speak. But how do we do things differently so that people don't get turned away?
Yeah, thanks, Councillor O'Leary. Sandra's last reflection question there around, what am I doing at an individual and organizational level to include the voice of people with lived experience? I think that's the place to start. And I would say that's where a budget line needs to be. So we're able to run the peer advisory committee and compensate people for their time and expertise. And that is a rarity in the system, where there is a budget line committed to meaningfully engaging people with lived experience. We've been fortunate to be able to do this through our funding, our annualized funding, but this is a pilot project and it will end at the end of 2022, where we'll be looking for additional funds to move this program forward. So I guess this is just a drop in the bucket. Like, the peer advisory committee is 12 individuals across Grey and Bruce, but there's so much more that can be done. And I would say, starting at the budget line, where's our budget and resourcing to meaningfully engage people in all levels of programming? But I do just want to push it back to Sandra to answer Councillor O'Leary's question, because we do kind of have Sandra as an expert representing the peer advisory on the hot seat now, so I don't want us to miss that opportunity. So I just wonder, are there any questions for Sandra?
I will just echo Allison's comment that affording the opportunity for those with lived experience to provide feedback with regards to programs, policy development that each service agency is considering is definitely advantageous. Often, as we sit around these task force meetings, we believe that we have the knowledge to know what is needed and what is wanted by the population that is being served. And we fail to recognize that that question is not to be answered by us sitting at the task force, but to be answered by those experiencing the effects of substance use disorder and mental health illness within the community.
Sandra, there were so many stories there, but there was one there where a crisis worker flat out misread the situation. Is that an isolated incident, or is because that's got nothing to do with budget? And I'd like to know more about that.
So Sandra, just before you jump in there, I just want to make it clear to everyone in the meeting that Sandra can't necessarily speak to each one of the stories that were presented because they're not necessarily her stories. Sandra can speak to her own experience with the system if she chooses. But if there are questions specific to those stories, I think that further engagement and conversation with the peer advisory
Well, fair
is
enough.
warranted.
Fair enough.
But Sandra, but go ahead and address Brian O'Leary's question.
I'm really trying to generalize it. Like
Certainly, I will speak to my own experience with regards to with the system. Unfortunately, it is not an isolated circumstance. Many people believe that it may not happen in their backyard, or they don't recognize that it's not an us or them situation. Mental health and addiction knows no boundary. It can affect anyone, brothers, sisters, husbands, wives, whomever. And unfortunately, those that react in such a way perhaps haven't had the experience and appreciation of what it may feel like to be on the receiving end of that. So certainly education within the services that are being provided, perhaps on a yearly basis, wouldn't go amiss.
So we could do better. Any other questions?
I think underlying this as well is certainly I think for organizations that provide mental health and addiction services, we do see lived experience as an asset. So in recruitment, whether it be for volunteer board positions or staff, that lived experience is seen as a strength as opposed to a weakness. So I think that that's an important piece to bring into it.
Absolutely, Clark. We have many strengths and assets that we can provide to services, whether that be on a volunteer basis, a board basis, or even as an employee basis.
Yeah. And I think, as employers as well, we want to, in terms of that psychological safety and safe environment, you want to be creating an environment where it is safe to acknowledge and speak of those issues as well, which is a bigger task. I mean, it's socially, it's still quite stigmatized, but have to start somewhere.
I'd just like to direct everyone on the call to the Drug Strategy website. On our landing page, there are links to resources for organizations that they can draw on. They're kind of like toolkits and guidelines on how to include people with lived experience. Some of them are specific to including people who use drugs. One of the underlying philosophies and foundation of harm reduction is to ensure that people who use drugs and have a history of drug use are routinely have a voice in the creation of programs and policies that affect them. So there are some very concrete guidelines on how to do that, recognizing that people who use drugs, there are some very specific, structural and environmental adjustments that need to be made to create safe environments, recognizing that substance use, for most substances anyway, is prohibited under the law. And so that creates a number of barriers to engaging people who use substances in this work. So it's not always intuitive on what to do and how to do it. So I really encourage people to check out those resources.
Just, thinking of the recommendations as well, I know that a crisis situation has brought this about, but I think as we've been hearing, there are many dimensions to it. And I would hope that we're not just going to try to douse the fire and then forget about it, but rather plant some seeds that may take years to bring to fruition, but they would bear fruit and lead to a better system and better environment as well. So I think that larger scale public education and shifting public attitude is really important. just last Thursday, I heard a presentation on problem on gambling and some of the, we often call it problem gambling, but just the rather ominous prediction of this one fellow who saw the development of the opioid crisis, and he sees the same conditions forming for gambling with the opening up of sports gambling. And gambling is another way to, it does give a dopamine hit, and it does provide that cessation of pain from a traumatic situation. So people who have experienced trauma are also vulnerable. With gambling, it can lead to loss of life savings, loss of housing, and there is a greater instance of suicide with that unsafe gambling behavior. It is also something, an area that is more socially acceptable, so it sort of goes under the radar and it's not regulated. And sort of indicative of that is that we have our addictions program, and we have a separate pocket of funding for a problem gambling position. It's not lumped in just with addiction counseling. It's a separate position, which really doesn't make sense when you really get down to the root behaviors and causes. It's addiction. So, but sorry, I got a little off track. But to my point, the original point, I hope we can cover off not just addressing the crisis, but creating a foundation for something longer.
Well, I'm glad you brought up gambling, but doesn't any addiction empty your pocketbook? People lose their wives, their house, regardless of it's not just gambling, correct?
Not just gambling, no, but gambling, it can happen in a flash. If somebody goes on a tear, just instantly. So it is, and as things are developing with the sort of lax regulation and the marketing that is going on right now, we're also sending messages to kids around the appropriateness and that behavior as well. And a lot of it focuses around, the presentation was around that concern around sports gambling and things, and how we can put safeguards in place. Other jurisdictions have sort of whistle to whistle, so no advertising during sports matches. But really, you can pretty much bet on anything. I think a word of caution that we should heed.
Okay, I don't see any other questions. We can wrap this up, but I just wanted to ask one more question. I'm not sure who I'm asking. Maybe Kevin can help. Has anything changed in the emergency room if someone is taken to emerge with, whether they're drunk or under the influence of something? Is the only way to get that person admitted is if they're going to, or if they've threatened to harm themselves? Or is there something that has changed that will have them admitted and dealt with a psychiatrist or some kind of professional?
Yeah, probably Steph will be on here, and Scott as well. But from our perspective, if they're a threat to themselves or somebody else, that's one way. Or if they're not capable of making a decision, and that is a difficult line sometimes to determine whether they're capable or not, as far as being able to understand the risks associated with their condition. We face it when we see people that overdose in the community. We want to take them to the hospital. They were just unconscious. Now they're conscious and alert. 5 minutes before they would be unconscious and not breathing. They won't go to the hospital. We can't force them to go. Those are kind of difficult situations. But my interpretation is if they're not a harm to themselves or others, that there's not a lot you can do as long as they're capable of making a decision.
And just in terms of those scenarios, often MHART workers are called in to do an assessment. But if the person is under the influence, they they can't make they can't do a proper assessment with regard to mental health. So they're a little stymied that way. They have to wait till the levels get to a point where they can have that conversation with them.
And I'll just add in there that often they'll be saying they don't choose to go to the hospital because of previous experiences that they've had at the hospital with regards to how they've been received and the language that they've heard around their visit to the hospital.
There are some, sorry.
No, go ahead, Clark.
You know, when I was in Timmins, we way back had a very committed detox center and volunteer group, and they actually started a withdrawal management system that was distributed. It was actually community based, so we didn't have beds in facility. It was all volunteer operated with under the oversight of the detox. But there are innovative models, and that model was assessed by it was the old Addiction Research Foundation back in the day, and had some really significant anecdotal successes of helping people that wouldn't have gone into the mainstream system, but were able to be assisted through that detoxing in the home in the community. So.
Okay, thanks, Clark. Sandra, you're a big part of this committee. Really appreciate your presentation today. Thank you so much. We're going to move on here. Item number 7 on the agenda. Is there any other business?
Sorry, Mr. Chair, I believe Allison had another comment.
Okay, Allison, go ahead.
There's just a quick one around we are talking about the hospital, and I'm conscious that and ERs, and I'm conscious that I'm not sure if we have anyone left on the meeting today who can speak to that from a service provider standpoint. So I did just want to reiterate that the stories that you heard today are based on individual experiences and shouldn't necessarily be generalized. And that the point that we're trying to drive home really is that you got to keep talking to people, you got to keep hearing their voice, you got to figure out what's going on. Because it is going to be different in every context, every setting, depending on who the staff are, what the environment is, who the client is. It's always, you can't brush it with the same stroke. So I just wanted to mention that. And I also wanted to just say, like, where organizations can start is offering that training, as Sandra mentioned, to frontline staff, to everyone in the organization, whether it's someone at reception or, the head of the ER, that training has started in many organizations, specifically around harm reduction and overdose response. But I just wanted to really reiterate that unlearning, that we're all trying to move forward together, but it's hard because there's a lot of unlearning that needs to happen. We've lived in a structure of prohibition for decades, where we criminalize, people with mental health and addiction challenges. So we all have to move forward together, and it's not really fair to point at one person where they are on their journey of learning, and say they don't get it or they didn't get it right. But really, we all have to do that unlearning, and I do it, every time I meet with the peer advisory committee, I unlearn a little bit and learn something new. So just wanted to end with that, and I see Sue has her hand up.
But I appreciate that. I just, the point I was trying to make is, like, I just think if anyone lands at the door of Emerge and is in a crisis, it doesn't sound like they're being treated the same as someone that's got chest pain and needs to be looked at right away. Because I know if you go in with chest pain, it's boom, you're right to the back and you're looked after immediately. But this situation or these situations that I hear about are not treated the same. So I that's where I'm going. That's what I want to learn more about and see if anything can be done about that. Okay, have I got everyone covered now? Oh, Sue Carlton. Sue, go ahead.
Thanks, Mr. Chair. And sorry to be so late with this question. I guess, and all the presentations are absolutely amazing. There's just so much to take in. I guess the thought that occurs to me is, are there times when someone needs help and their own family members are the one that holds them back because they don't want to admit that there's addiction or problems within their own families? And is that part of the problem? Is that, and I don't know how we'd ever cope or work with that, but I'm just curious, are there instances where family members are holding somebody back from getting help? Thank you. Thanks to everybody who's presented today as well.
Family dynamics can certainly play into treatment access and whatnot, but I think the bottom line is perhaps that may be an issue because of the resulting stigma that happens if that individual or that family member needs to acknowledge that a son or a daughter or a spouse or an extended family member has a substance use disorder or a mental health illness. So bottom line is we need to start at that stigma level and shatter it.
Okay, Clark.
Yeah, it's a great question, and I think an important point. Typically, we see it from the other end where family members are desperate to try to seek some help for their loved one. But there are, I think, situations where people come into provision of service, and it's important to educate their support network as to what's going on, and that way they can provide better support and informed support for the individual. There will be relapses, and it's not the end of the world. It's not the end of the road. It's just a bump in the road. So it's really important to engage family and that natural network.
Okay, thanks again to everyone, all the presenters, and that was a great meeting. So we have no other business. Next meeting dates. Kim, did you want to go with the date we discussed before, or do you want to wait?
No, I think just to advise everyone that our two presenters that we weren't able to get to today have very graciously agreed that they could make themselves available on the 7th of July. So if possible, we'll have an additional meeting on July 7th in order to accommodate those two presentations. So I'd like to thank them both for making that possible, and I hope all of you will be able to join us.
Great. Okay, thanks, Kim. Item 9 is adjournment. I need a mover and a seconder. Councillor Carlton and Councillor Mackey. All those in favor? And that is carried. Thanks again, everyone. Have a great day. Bye for now.